Well, good afternoon, all, and thank you all for joining us. So today we'll be discussing mental health, billing, and coding in the RHC. So quickly, too, I just want to thank UAMS, the Psychiatric Research Institute, and Arkansas Rural Health Partnership for partnering with us today to bring you this webinar. So, okay, so on to who we are. Moving on to the next slide there. So Rural Med is based in Holdridge, Nebraska, but we assist rural health clinics and critical access hospitals across the United States. Really, our mission is just to provide resources to rural areas to overall help keep rural health care just strong and alive. Sam and I are part of the revenue cycle service line of Rural Med Management Resources. And essentially, we're just really committed to helping keep rural healthcare organizations keep their revenue cycles strong and just overall give them the tools and resources needed. So I am Haley Prosser. I am the Director of Revenue Cycle Services here at Rural Med. And I have an in-depth knowledge of both hospital and physician revenue cycles, including an extensive background in critical access hospital and rural health clinic billing and coding. That's truly where my passion is definitely in rural healthcare. I've had experiences, of course, in leading revenue cycles at multiple critical access hospitals, but also have been at large multi-hospital systems and some physician practices. I really enjoy solving the most difficult revenue cycle challenges, going into the clinics that may be struggling with some workflow or process issues and getting some items cleaned up for them so that they can really have a successful revenue cycle and reap the benefits revenue-wise. Or financially from that. And then Samantha, she is my counterpart here, a team member at Rural Med, and she has more than 15 years of experience in healthcare, working in administration, education, reimbursement, billing, and coding. And she's also a fantastic auditor and consultant. She enjoys sharing her knowledge and experiences as an active coding advocate, and has been featured speakers at multiple venues such as AAPC, 3M, and many other healthcare organizations. She is also actively involved with several coding chapters and has held president positions in our local chapters. So in addition to primary care, she's worked in a lot of different specialties. She has a wealth of knowledge. So this includes emergency medicine, general surgery, neurosurgery, orthopedics, etc. Okay, so this is just a quick disclaimer. I know that Chris went through several disclaimers, but essentially it's just noting that today's information is provided for educational purposes only. Okay, so on to the next slide. So our objectives here today are going to be the following three items. So we want to focus on maximizing reimbursement and patient care through RHC behavioral health screenings and services. So just giving you the tools to really use those screening services to your benefit, both financially and through patient care. And then we want to make sure that you have the proper documentation and billing for these screening services within the RHC, so we'll provide you with that information. And then lastly, we want to make sure that you're ensuring you capture the appropriate revenue for visits in which patients may screen positive for behavioral health problems, or there's some additional other overlooked reimbursement opportunities that we want to share with you today. Okay, on to the next slide here. So we've broken, before we get started into the different sections, I just wanted to go over this quickly because we've broken out Medicare into two different sections. One for preventative screening services and one for non-preventative screening services. And the reason we did this is just because Medicare preventative codes, they have different billing and coding requirements. So any of these Medicare qualifying preventative visit codes, they're specified by CMS in a list here, which can be found at that following link. They're on your screen. And these services qualify as a standalone visit. Now, what Medicare considers non-preventative codes is any screening code not on this designated CMS list, but it's still a Medicare allowable code. So you'll still find that code, for example, on their fee schedule, but just not necessarily on that preventative billing list or preventative code list for them. So these codes, these non-preventative codes can definitely still be billed, but the most important note here is that they do not qualify for a standalone visit. So you'll need to bill them with another medical service like an E&M office visit. Okay, so now I'm going to hand it over to Sam, and she's going to begin walking through the Medicare preventative services coding.
Great. Good morning, everyone, or afternoon, I should say. So the first ones that I wanted to start with for the series of codes and services that Medicare does provide are the preventative services codes. I know when we think of behavioral health, we automatically, everything with depression screenings comes to mind, anxiety, or sometimes substance abuse codes. But there are often some overlooked codes that really go along with mental and behavioral health for a rural health clinic. So I also want to touch base on those today. So the most common ones we always know are the depression screening and the alcohol screening. But there are also other screening codes that we'll touch base on for STIs and also behavioral therapy for cardiovascular disease and obesity. So I think the one that we're most familiar with, I think, as a whole, would be the Medicare depression screenings. G0444 is actually the annual Medicare depression screening. This is covered by Medicare once per calendar year. So we do need to be mindful that 11 calendar months have passed before the patient becomes eligible again for that service. This is not meant to be billed during the course of the welcome or annual Medicare wellness visits. Those are considered just a component of those services. So we want to make sure that we don't include that in our billing for those. Medicare does cover this as a threshold code, and you'll see that and notice that all of the preventative services are what I consider a threshold code. So what that really means is if it says 15 minutes or 30 minutes, you need to meet that minimum threshold of half that time in order to qualify to bill that service. And I'll kind of go through that documentation in just a bit since it is the same for all sets of codes. So in this case, this is considered a 15-minute screening. So a minimum of 8 minutes should be documented just as a best practice to ensure that you're meeting all of the guideline criteria. The great part about the Medicare depression screening is you really can tailor it to fit what you're comfortable with in your organization and in your clinic, because most of the standardized instruments are available to be utilized for this. So obviously the most common one we have is the PHQ-9 questionnaire. But some providers prefer the BDI for the Beck Depression Inventory. I believe there's a depression scale, the geriatric depression scale can also be used. It's geared a bit more towards seniors, and even the anxiety depression scale from Duke. So you can really choose which instrument you'd like to utilize for your patient in order to fit that criteria. The diagnosis code for these, I do want to point out on some of these, that is a really common misconception that I really see in a lot of billing and coding for these services. In order to be paid, instead of using a depression screening code, Medicare requires it to reflect the Z00 diagnosis code for the wellness visit, since this is an annual wellness visit screening for depression. This does differ a bit from other Medicare depression screenings, so I do want to clarify that. We'll go into more in depth about those. Medicare does have a code for annual alcohol misuse screenings, and that's a really common code that I don't see a lot of rural health clinics or even other clinics that are freestanding or privately owned utilizing. And the part that I love about this is open to all Medicare patients as a form of a risk assessment to identify individuals who may be misusing alcohol. So it's not necessarily something that you have to maybe have a high suspicion or a patient is at higher risk for alcohol misuse. This is really intended as a use for risk-based assessment to ensure that those individuals who may or may not have an alcohol misuse issue in their lives aren't overlooked. This is a 11-month calendar, has 11 months, excuse me, calendar has to have passed in order for this to be covered. And this does follow the same guidelines as the depression screening. So this is not eligible on your welcome to Medicare visits or your annual preventative exam. So this would be separate. There is no requirement for any brief interventions or any structured instruments to do this screening. But the benefit is to this for those patients who do screen positive on your misuse screenings. There is a separate CPT code for that counseling, the G0443 that we'll talk about. For this screening code, we should use the substance abuse screening code, or if you do identify the patient has screened positive for alcohol misuse, then you would go ahead and code that actual alcohol uncomplicated use code. So if you do have a patient in your clinic that is screened positive for alcohol misuse, Medicare also covers counseling for those patients who screen up to 4 times per year for those patients who screen positive. I think the great piece with this is a way for patients to remain in their primary provider's care. Most of the time, it's a sensitive, delicate subject for patients. So the referral to a substance abuse program or outside organizations like Alcoholics Anonymous sometimes is very uncomfortable for a patient to want to reach out and talk to someone about that. But when they already have a relationship that they're comfortable with their providers, this gives them the ability to come in and allows the provider to actually counsel them and discuss maybe changing some of those behaviors or identifying what is causing the alcohol misuse, whether it's environmental issues or psychological issues that could be driving that information, and allows the patient to still feel comfortable because they have that relationship already with the provider. Medicare also covers G0445. And we consider this HIBC as just the shortened term that Medicare utilizes for this. And this is high intensity behavior therapy for STIs. And it's not something that we commonly think about or commonly see when we think about mental health. But really, our mental wellness drives a lot of behavioral factors for us. So, even with identifying behaviors for sexually transmitted illnesses, if a patient is exhibiting high risk behaviors due to bereavement in their lives or something that has caused just socioeconomic factors that might be driving that mental wellness for them, we can also screen and do behavioral therapy. This is actually covered semi-annually for Medicare beneficiaries. So it does differ from the depression screening and the alcohol use and abuse screening because they do cover it twice per calendar year. And this is really geared towards education and prevention on how providers can help change those high risk behaviors that can lead to STIs. So for those diagnosis code sets, when you would bill these codes, you want to look at the Z70 code range. That is other concerns related to sexual behaviors. What I like about these codes the most, and I think that you can kind of see as we've grouped these, a lot of these can build from each other. When you think about the depression screening, if the depression is driving the alcohol use, if the depression is driving high risk sexual behavior, this can really be an encompassing program aimed at all aspects of wellness for patients. And this is one of the most important treatments and screenings for prevention that Medicare offers. They also offer IBT for cardiovascular disease. This is covered annually for Medicare beneficiaries. They only require 15 minutes for this code, so essentially 8 minutes of counseling and therapy. And this is really just to encourage the use of aspirin for the primary prevention of cardiovascular disease. Um, when the benefits obviously outweigh the risk in men ages 45 to 79 and women ages 55 to 79. And when you really think about this, there are only 4% of the Medicare population that is under 45 years of age for men and 55 years of age for women. So the vast majority of Medicare beneficiaries really should receive these three components. And the intensive behavioral counseling it's meant to promote that healthy diet, the healthy wellness that's recommended to close to over 100% of the population, just due to the prevalence of known risk factors. So this includes risk counseling for any of your patients who also have chronic conditions like hyperlipidemia, hypertension, if they're advancing in age, or if they have any other known risk factors for cardiovascular disease. And that can also be family as well. The third component is screening for high blood pressure in adults ages 18 or over. And for this particular CPT code, just utilizing the diagnosis for the corresponding cardiovascular condition. You can utilize the screening for cardiovascular conditions, but Medicare does prefer, according to their website information, that you put the corresponding condition, whether that is their own condition or if it's a family history condition, for coverage of this. The last code is IPT for obesity. And again, this is one of those really corresponding mental wellness codes. When we think about treating anxiety or depression, a lot of times those patients, how they comfort themselves is through sometimes overeating or eating improper diets because they're not taking care of themselves. So this really consists of three components, and I think a lot of people are most familiar with this code as well. It is screening for obesity in adults that have a BMI that is over 30. It is a dietary nutritional assessment, and then intensive behavioral counseling, just so that they can change their mindset. And whether that's using coping skills or mechanisms for anxiety and depression, or whether that's structured exercise routines focused on a diet for intervention. The Medicare coverage for this is greater than once per year. They do have a scheduled coverage of one visit weekly for the first month. And then for the next 5 months, they allow biweekly visits. And then the final 6 months, as long as they're continuing to meet weight loss goals, the Medicare continues to cover those visits once a month for 6 months. So the great part is it's 22 visits over the course of a year that they can focus on that behavioral therapy to make those changes in their lifestyle.
Okay, so most of you on this call are probably already familiar with what constitutes a qualifying RHC visit, but I just wanted to ensure I added this information in case we have some that are maybe new to RHC billing or coding. So a qualifying RHC visit is one that is a face-to-face visit with one of the providers you see listed here. So nurse practitioner, PA, etc. And it is, of course, requires medically necessary, meaning that essentially a provider skill set is required. So for example, if a provider skill set is not required for an allergy injection, and even if that physician would give that allergy injection, that does not constitute an RHC qualifying visit. Because again, it wasn't medically necessary for that provider to utilize their skill set for that particular service. So just keep that in mind when you're thinking about RHC qualifying visits. As far as place of service goes, RHC visits can be provided in several areas. So, you know, the obvious ones, the clinic, but we can also provide RHC services within the patient home, nursing home, swing bed, etc. Okay, moving on to the next slide. So as mentioned in one of the first slides, any code that Medicare constitutes a preventative service code can be billed as a standalone RHC visit. So you'll want to bill these services on a UB04 with a type of bill 71X. You'll want to ensure each preventative service is on a separate line item with a 52X revenue code. If there's a medical visit that day, such as a 99213, then you'll want to make sure you append that CG modifier to that medical service. If there's no medical visit that day and you're just billing a preventative service, or maybe even multiple preventative services, so multiple G codes, you'll want to add the CG modifier on that main preventive service. And then, like I just mentioned, you can bill multiple G codes on one claim, so multiple preventative services on one claim. Such as an alcohol screening and a depression screening. One important point to remember is to not bundle these preventative services into the first line item like you typically would with other RHC claims. I always recommend that clinics try and customize their EHR system logic so that these preventative service codes are always excluded from that roll-up logic. Older systems may struggle doing this, but if you're utilizing an updated EHR or an EHR connected to a larger hospital system, such as Cerner or Epic, they should definitely be able to accommodate this request for you. Okay, moving on to the next slide. So these qualified services are paid at the RHC's all-inclusive rate, also known as the AIR. As previously mentioned, they can be billed alone or with another service. So potentially, you can just get an AIR if you're doing, say, a depression screening. Another important note here is that if a qualified preventative service was performed the same day as another medical visit, like a 99213, only one AIR will be paid. But just remember that these additional charges for these screenings are reflected in your cost report settlement. So it's important that you capture, all of these screenings in addition to your E&M visits. One exception here, though, is that if an initial preventative physical examination, so an IPPE visit, was to occur the same day as another qualifying visit, 2 visits can be billed, and then therefore you can get 2 all-inclusive rates for that particular day. And then for all of the designated Medicare preventative services, again, that are listed on that CMS list, coinsurance and deductible are waived. Okay, moving on to the next slide. So here I've just provided some examples of billing and reimbursement for different situations. So the first situation is if you're billing an office visit and a preventative service, such as an annual alcohol misuse screening. As you can see here, you'll be reimbursed your AIR, and then the alcohol misuse screening will be bundled into that AIR. Coinsurance and deductible will apply to that office visit, but not to the preventative service code. So notice too that G0442 is not bundled into the 99213. So that is an important differentiation from your normal RHC billing practices with these preventative services. So the second situation is when you are billing a standalone preventative service, such as an alcohol misuse screening, and you're just billing that without an office visit. So you can receive your AIR for that. And again, no coinsurance or deductible is applicable. The third situation is if you're billing an office visit and an IPPE, so that initial preventative exam. The office visit will need to be billed with both a CG and a 25 modifier, which I know is unique. You don't often see that 25 modifier used just because the CG typically stands in place for that. But the 25 modifier is used if you are truly billing two separate visits. And in this case, you would be. So you'll be paid because of that 25 modifier, you will be paid at you'll be paid two visit rates for that day. And then of course your office visit coinsurance will be applied. In your IPPE, you will not have coinsurance or deductible applied. Okay, so now I'm going to pass it back over to Sam, and she's going to go over some Medicare screenings that are non-preventative screenings.
So Medicare also covers a second set of codes. These are non-preventative screening codes. These are covered more than once annually. And a lot of times they're confused with the annual Medicare codes. So it really is important to note the difference of the codes. Most of them still have the same documentation requirements that we'll talk about, but they are billed differently during the course of the year and the visits. So there is the screening for depression. There's also the screening for alcohol and substance abuse. And that is one note. This does differ from the alcohol misuse screen that we previously talked about. And then there's BHI and behavioral health integration and chronic care management codes, as well as the smoking cessation and counseling codes that Medicare covers. So the 96127 CPT code, we always call it the depression screening, and I know I'm just as guilty of that, but it is actually described as a brief emotional screen. The main difference between G0444 and 96127 is Medicare only covers the G code once per year, and it is considered that annual preventative service. 96127 can be used for all major medical insurance as well as Medicare for other than annual wellness visits. So this is not something that you would want to bill during the course of the annual wellness visit. For Medicare's emotional screening, they cover this 4 times per calendar year. And this encompasses so much more than just a depression screening. This covers screenings for ADHD, anxiety, and other mental health conditions. And this is billable per instrument, up to 4 instruments per visit. So if we need to utilize more than one instrument, if you have a patient that you suspect has combination of anxiety and depression, you'll want to utilize both of those instruments and bill 2 units of that for the same visit to cover those instruments being utilized. The same standard instruments do apply. I've got a list of those for you guys after the presentation. So the PHQ-9, the GDS, all of those standardized instruments you can use and tailor to your organization. The common diagnosis code for this with Medicare is Z1389. That's just an encounter for screening for other disorders. But it is important that you utilize that code rather than depression. Otherwise, they don't cover that as well. Medicare's alcohol and substance abuse screening, G0396, can be utilized up to 4 times a year as well. And this is for patients who are at higher risk for substance abuse. And that kind of is a key individual factor with this code, is they do cover this for substance abuse issues. So if you suspect a patient has an opioid use disorder, utilizing this up to 4 times per year can allow you to track monitoring a response to treatment if you are providing treatment and behavioral health integration services to this patient. This would be used in conjunction with other services that you are providing to the patient throughout the course of the year. G051, I know this has been commonly referred to often as chronic care management or general care management, but you actually have 2 options for this billing code in an RHC. This does cover at least 20 minutes of clinical staff time per calendar month. So that does include time that is not face-to-face with the provider. Your option A is general care management, and that is 2 or more chronic conditions. So this is chronic care management essentially for this. But option B for this code is a patient with any behavioral or psychiatric condition being treated by a rural health clinic provider that is determined to warrant BHI service. So it's any eligible condition. So that is really what the provider deems necessary at that time of service. So this can be anxiety, depression, PTSD. It really depends on that patient, which chronic condition and which psychiatric condition qualifies for that. And it is important to note, this is also time during the calendar month that any of your administrative or clinical staff follow up with the patient is going to be included in that time. Some very specific requirements for this code that differ from other codes is the patient cannot be on any end-stage renal disease treatment, home health, transitional care management, or hospice. So if they are on those services, they would not qualify for the behavioral health integration. We do have to have verbal or written consent documented with an opt-out method available. And we need to actually develop a comprehensive care plan and provide the patient with a copy of that care plan, whether that is ongoing meeting with the provider a specified amount of times per month, if we're referring them to another type of therapy. We do ensure we have that documented in the healthcare plan. They do need to have 24/7 access to care. And that is just a way to make contact with their provider. So whether we want to utilize a secure portal for email contact, phone calls, or an answering service, as long as they are able to contact the provider in some shape or form, we're able to do that and provide that service. And it also allows the transmission of the care plan by fax. So when we think about Medicare patients and how we can implement these preventative programs in a rural health clinic and how that actually impacts not only the patient, but yourselves as well as providers, one of the cases that we can think of is if a Medicare beneficiary presents for follow-up with their diabetes and hypertension, if a provider actually has them complete just a self-assessment, the PHQ-9, for example, and they identify that positive depression screening as a result, in a brief discussion, the provider notes that they have additional struggles on a day-to-day basis and decide to provide a low-dose medication to trial the patient on to see if that's of any benefit. That is a potential evaluation and management level increase at that time. And then a way to incorporate ongoing services targeted at that patient would be the behavioral health integration. So if the patient agrees to participate as a starting point to discuss behavioral changes, any risk factors, or any methods that they can target and positively impact that mental wellness, then that can be billed monthly, ongoing, up to 4 times per calendar year with the screenings as an ongoing follow-up for that patient. So then you have, in addition, the screenings and the clinical staff time, your monthly contact included for increase in revenue for the RHC. And Haley, if you want to talk about the reimbursement.
Definitely. Okay, so I've kind of broken it out into 2 different codes. You're going to be billed or you're going to bill and be reimbursed a little bit differently on a couple of these screenings. So the smoking counseling, depression screening, and alcohol substance abuse screening, they are not considered qualifying visits. So you'll want to bill those on a UB with a type of bill 71X. You'll want to list that screening CPT in the secondary position to the office visit and bundle that charge for the screening into the qualifying visit code, so such as a 99213. The charge on that screening code that's bundled, that follows standard RHC billing practices. It must be a penny or greater. So this is, I see, just clinic preference. Some just leave that standard charge, for example, $15 and bundle it. While some just put a penny on that second charge they're bundling into the first line item. So again, Medicare accepts it either way, as long as you're bundling all your charges into that main line item with your CG modifier. So I provided you with an example here. So again, since these screenings are not considered preventative, you bundle that up, and then it will be included in your all-inclusive rate. So you may be asking to, if that screening is included within your, AIR, then why do we even bother billing it? Because we're not going to get necessarily additional reimbursement right now. But just remember, since RHCs are reimbursed based on cost, the higher your costs, so the higher your charges, then the greater your cost report settlement will be, and then that floats on to your next year's visit rate, which can increase. So just remember to make sure that you capture these screenings. Okay, moving on to the next slide. Behavioral health integration is billed a little bit differently. It's not considered a preventative service, but it is separately reimbursable from your normal just AIR rate. So here you'll want to bill on a UB04 with a 711 type of bill. You can bill it with other services, or you can bill it standalone. So either way, most clinics I do see bill these standalone just because it can kind of create some complication when you're trying to follow up on these. Again, these services are not bundled into your all-inclusive rate, but they're instead an average payment rate of the national non-facility physician fee schedule codes that you see here on the screen. And so what these codes are going to be your chronic care management and behavioral health integration codes for non-RHC clinics. So that's why they've taken the average of that, and then they just pay RHCs that average, which they haven't released this year, but last year is about $65. And they pay RHCs that average, whether they're doing behavioral health integration or chronic care management. It's just that one code. Coinsurance and deductibles applied to these services. I just do want to provide a note of caution here to make sure you include that financial information in your consents. The most common thing I see in clinics is that patients call and are confused why they're getting a bill when they've never really had an office visit. They've just been receiving phone calls from like a nurse or something like that for care management. So just make sure you're including that within your financial consents. Okay, moving on to the next piece here. I'll let Sam take it back over.
The last set of codes is really meant for commercial and Medicaid screenings. These services, Medicare always utilizes generally G codes. So these codes are generally just a bit different. The depression screening is the same for Medicare and commercial and Medicaid carriers. But the CPT codes you'll notice change for the alcohol and substance abuse screenings, as well as the chronic care management and smoking cessation codes. Most payers do follow CMS guidelines with the emotional screening. They allow it 4 times per calendar year, and it is billable per instrument, again, up to 4 per instrument. So the biggest key piece, like I talked about, is just to remember it covers so many other issues rather than just depression. There are suicidal risk screenings, somatic symptom disorders, substance abuse can also be included in this for emotional screenings to see if there's any underlying mental illness issues that are driving those substance abuse issues. So they really are meant to be used in tandem with other screenings based on the patient's needs. And this is just a set of some additional examples of emotional assessment tools. And especially when you get into your commercial and Medicaid carriers, there are also tools and assessments utilized for children as well that are geared towards a younger age. The ages and stages questionnaire for the social emotional section, the modified checklist for autism and toddlers. So there are a lot of scales out there that you can utilize. The alcohol and substance abuse screening with brief counseling does also have its own set of tools. And I did just want to list a couple tools here for the screening risk. The opioid risk tool is a great tool to use. I always recommend, as well as the NIDA for the drug risk screening tool as well. But this really can be decided upon based on what your clinic prefers and what the provider feels more comfortable with. For the alcohol substance abuse screening, non-Medicare payers can bill this up to 2 times per year for Medicaid payers. That is one key difference. Most commercial carriers still do cover the alcohol and substance abuse screening up to 4 times per year. For patients who are considered higher risk for substance abuse or who a provider has identified as a current substance abuse abuser or a user of any type of substance, whether that is a medication, non-prescribed, as well as alcohol. The next piece is obesity counseling. They do consider this IBT for intensive behavioral therapy, and they do follow Medicare criteria for this with Medicaid and commercial carriers. A couple things that I do want to point out, check with your individual payer if you decide to offer intensive behavioral therapy counseling for obesity in conjunction with a wellness program, whether that's depression or BHI treatment. You do want to check your payer to see if they use the Medicare G codes. I know that United Healthcare as well as Aetna cover this under Medicare's G code versus the 99401 or the 99402 for those treatments. I did want to just note the medical nutritional therapy is not interchangeably used with this counseling code. Those are separate services. And a lot of times payers will carry different guidelines for those services. So you do want to check the guidelines to make sure that we are following appropriate. The behavioral health integration code for commercial and Medicaid carriers is the 99484. It does follow the 20 minutes of clinical staff time per calendar month. And that does include the initial assessment, initiating the visit if that is not separately billed already, systematic assessments, monitoring of those clinical rating scales. So any depression screenings that need to occur during the course of that behavioral health integration, and then a continuous relationship with a designated member of the care team. And again, these are eligible conditions that is based on the clinical judgment of the billing practitioner. So if they determine that BHI services are warranted for that particular patient, you would just bill with those coverage codes for that illness. Developmental screenings are something obviously we see more in children than anything else, but it is important to kind of think about those with your wellness programs for mental health. A lot of these developmental milestones are really geared towards mental health as well, whether that's an ADHD screening or an autism screening. These are billed much the same way as our depression screening. So they are billable per instrument, up to 4 instruments per visit. These are good because they can be used in conjunction with both acute preventative wellness visits. So they encompass both pieces. And I wanted to list just a couple of the most common diagnosis codes for coverage, whether that's the screening for autism, if you are screening a potential patient that you believe could have an autism spectrum disorder, or screening just for global developmental delays are the most common. I do want to keep in mind, this is a developmental limited assessment. So you can see I put the limited assessment tools, the PEDS and the ADHD scale. But sometimes we have patients that we already have suspicion that they do meet the criteria for something like an autism spectrum disorder. And we're not quite ready to actually move them on and refer them to a different physician or a different care, especially in rural health clinic areas where, again, you have that relationship. The family's already comfortable with the provider. So there is actually an extended testing. 96112 is for developmental screening, extended testing. And this is for use with more extended assessment tools. the Bailey scales of infant development, the CELF. These scales are more geared towards in-depth cognitive screenings. This is typically performed by a physician when a developmental delay is already been noted and you need more extensive testing required. This is a time-based code. About 30 minutes is what they do recommend. You do need to meet that threshold of 15 minutes. And these are just a few of the developmental assessment tools. Again, same as the depression screenings, these are ones that if you feel more comfortable with, or if you have a questionnaire developmental assessment tool that you feel better fits the patient, utilizing those standardized instruments for that extended testing or the limited testing are billable. So in your commercial and Medicaid preventative program in your RHC, this is just another case scenario of how this can actually benefit the patient and increase your reimbursement in the RHC clinic as well. So if we have a commercially insured patient that is presenting from hospitalization due to alcoholic gastritis, administering a alcohol substance abuse screening at that time and discussing the positive results with the patient, we will see a potential E&M level increase, as well as a billable substance abuse screening code, as well as a brief emotional screening. If the patient really seems like their alcohol use is being driven from maybe some anxiety or depression that they're having to cope with, we want to include that emotional screening. Well, is all three of those would be billable on that date of service. The patient, if they're reluctant to seek outside services directed at their alcohol abuse, but they are willing to discuss their feelings and their situation with the healthcare provider at that time, this is something that we can enroll them in behavioral health integration monthly, and then utilize those ongoing brief alcohol counseling and screening tools up to 4 times during the course of the year to kind of monitor how they're actually doing, if they're making progress, or at that point need to be referred to another outside organization to help target more of their behavioral issues. So you can see there really is a great opportunity for billing additional codes and building a program really tailored at gearing towards the patient care. And I will let Haley talk a little bit about the commercial billing and reimbursement. Oh, Haley, I think you're
I
on mute.
apologize. I had to unmute myself there. Okay, so commercial billing and reimbursement. So commercial payers, they don't recognize that RHC status. So for RHCs, they're just another clinic. So billing is straightforward, like you bill everything else for a commercial payer. Just going to put that on a 1500 with the appropriate place of service. Your reimbursement will just be based upon your contracted rates. Make sure you review your professional fee schedule. And also just to note, RHCs are really often surprised at how much those screening codes can increase that reimbursement. So just keep that in mind. Okay, on to the next slide. So Medicaid, RHC billing and reimbursement. Again, here you're going to follow your standard RHC Medicaid billing practices. However, for EPSD and AR kids first screenings, you'll want to build the appropriate code and modifier on a 1500, and then that individual encounter rate will be reimbursed. But just make sure you note that the encounter rate will only be reimbursed if the charge for the service submitted on the claim is greater or equal to the RHC's encounter rate. Okay. Moving on, I'll let Sam take it back over for a bit.
I know we're kind of low on time, so I am going to try to touch base on this as quickly as possible. So for all of these codes, whether it is a preventative or a non-preventative screening or preventative service, they really follow the same best practice for documentation. And that is really the great part. So there's not a lot of information having to remember what you have to document on a depression screen versus what you need to document on an alcohol abuse screen. So really is just best practice to document the patient's name in the medical record if it's someone other than the patient that's informing you, if you're talking to maybe a spouse or a caregiver, to document that relationship of the informant, the instrument's name and the score. If you would like to keep a copy of this in the medical records, scanning that in is always good practice as well. And then document the provider reviewed the score in the context of the patient's presentation. So really what drove you to decide to actually go ahead and perform that screening on that patient. And again, all time-based codes needs to meet the threshold. So just documenting that that threshold level was met is actually really best practice just for coverage. The U.S. Preventative Services Task Force actually documented, I believe a couple of years ago, the 5 A's approach for documentation for any patients receiving preventative and screening services. So this is just really recommended by CMS as well as most outside and commercial carriers to describe the services that you're rendering. So the 5 A's approach is to ask, assess behavior risk and factors affecting the choice of that patient's behavior and change goals, to advise and give clear, specific, documented personal behavior change advice, whether that is diet, lifestyle, encouraging Alcoholics Anonymous meetings or encouraging emotional support, whether that is with family members or discussing information with the provider ongoing. Document the agreeability of the patient. So collaboratively select appropriate treatment goals and methods based on the patient's interest and their willingness to attempt to meet these goals ongoing. Assist using behavioral change techniques, whether that is self-help, whether that is group treatment, ongoing outside counseling or aid by any community involvement to help the patient in achieving their goals. And then arrange, if they're scheduling any follow-up contacts, whether that's by in-person or by phone, that they follow up with the clinic to provide that ongoing assistance and support. So this is really a great approach, whether you're documenting a depression screening, a follow-up screening for obesity. Documenting by this 5 A's approach will actually keep you compliant with all of your documentation for any preventative or screening services. So really the benefit.
I'm sorry, I just want to jump in real quick. For those who came in late to the presentation, could you please go ahead and put your full name, degree or credentials, and your email to receive continuing education credit for this presentation? Thank you. Okay.
Great. And just quickly, the benefits for the patient really is early detection and treatment, and providing proactive rather than reactive care. A lot of these are actually only addressed or treated as a secondary concern or often overlooked at visits. So targeting and focusing this really helps the patient benefit from a wellness perspective. And really that familiarity with the provider. Often they are already participating with the provider, they have that relationship, and that really drives the patient to actually participate in these preventative and counseling services. And then there are benefits for the clinic as well. And I'm going to turn this over to Haley for that last piece.
Yep, so this is just the last slide. I know we're up against time, so I'll just touch on this briefly. I've broken it out into Medicare benefits versus commercial and Medicaid. Medicare benefits, just remember that qualifying preventative services can be billed as a standalone visit. So this increases the number of RHC visits that you have per year, so increasing the number of errors you receive. And as I mentioned previously, definitely some cost report benefits. RHCs are reimbursed at that error, but remember that higher cost equals higher charges, which is reflected in the cost report. So therefore, anytime you have screenings, or if you can increase that E&M, as Sam said, so we can, because you're counseling now on, say, a positive depression screen, you can increase that E&M maybe up a level. You have now an increased charge. So therefore, that's reflected in the cost reports, hopefully increasing your overall per visit rate. So again, Medicaid and commercial, that's just immediate additional revenue. So we really did not leave any time for questions. That's, I believe, on the next slide. Sorry, we do have some resources. Sorry, Sam. Go ahead with that.
These are just some resources if you're interested in finding out some standardized tools that you can use, the Medicare Preventative Services chart for any other services. These are just some resources and links available that we can give to you.
And Sam, if you just want to pop up our contact information too, and then
Definitely.
so here's our contact information. We can stick around for another, 5 or so minutes, 5 or 10 minutes, and answer some questions. Otherwise, definitely reach out to either Sam or I, and here's our email and cell phones, and we can get those answered for you. So I will turn it back over to Chris.
Thank you. Thank you so much, Haley. Thank you so much, Samantha, for bringing this wonderful presentation to us. It's very informative, and I think our clinics will hopefully take advantage of all of this information you gave us. Also, a big thank you to Joe for introducing us to you two ladies and bringing us this wonderful presentation to us. All right, folks, do we have any questions? I know we're really short on time. And also, just again, if you haven't already, please put your information so that you can receive credit, and plus so I can mail out or email out the evaluations on this presentation. We really appreciate anything, all responses of how this helps and what else we can bring to you from the RPOP program.